Hello and welcome to this webinar timed to Universal Health Coverage Day and the last of our Spotlight webinars for our 200-year anniversary. My name is Jessamy Bagenal and I'm a Senior Executive Editor at The Lancet. I'll be hosting today's webinar with my colleague Miriam Sabin, who's an Executive Editor for The Lancet based in North America. Throughout our 200th year anniversary, we have drawn attention to the most critical issues impacting health globally, the extraordinary people involved in tackling them, and the voices of those most impacted. For 5 spotlights, we have run a program of activities to bring these issues to life and convene the right people and resources in order to drive change in these areas. Our spotlights have covered child and adolescent health, health and climate change, mental health, research for health, and universal health coverage. We want to say thank you to everyone who has joined us this year to celebrate 200 years of The Lancet. This milestone belongs to every author, peer reviewer, funder, partner, and colleague, and to all the patients and participants who make the research we publish possible. As we move toward our 201st year, we remain committed to achieving our mission that medicine must serve society, that knowledge must transform society, and that the best science must lead to better lives. In preparation for this webinar, we looked back through many of the series and commissions that the Lancet Group has published over the last decade on universal health coverage. This incredible and exciting concept that means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. But delivering on the universal health coverage promise is difficult. As a health community, we are not on track to make meaningful global progress to universal health coverage by 2030 as part of the Sustainable Development Agenda. We want to look back so we can look forward. We've chosen 4 commissions that look at universal health coverage from different angles. And these are Global Health 2035, the Lancet Commission on Investing in Health, the Lancet Global Health Commission on Financing Primary Healthcare, putting people at the centre, the Lancet Global Health Commission on High Quality Health Systems in the Sustainable Development Goals era, Time for a Revolution, and the Lancet Nigeria Commission, Investing in Health and the Future of a Nation. You will hear from presentations from representatives of each author group, and then hear some reflections on this from Freddie Sengoba. Finally, we'll have a panel discussion and open up the floor for questions and answers from our audience. So please do participate. And I hope I'm now going to read our housekeeping slide to fill you in on exactly how you can do that. So attendees are welcome to submit questions throughout the presentation. Just use the Ask a Question box on the dashboard. On the webinar dashboard, you will see a box with related Lancet 200-year resources. A link to our Spotlight on Universal Health Coverage content is featured and will take you to thelancet.com. Please take a look at that content. It's been carefully curated over the year. You can adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences. A link to the on-demand version of the webinar will be emailed to everyone once the webinar has concluded, so you can catch up on it in your own time. And once the webinar has finished, we will send you a very brief feedback form. So please do let us know what you think of them, whether the quality was good and whether you enjoyed them. I am now going to hand over to my colleague Miriam, who's going to introduce our guest speakers. I hope you enjoyed today. I'm really looking forward to it. Let's begin.
Thank you very much, Jessamy, and it's my pleasure to be here and co-host on this really important day on Universal Health Coverage Day. My name's Miriam Lewis-Sabin. I'm the North American Executive Editor for The Lancet. I'm based in New York City, and I am delighted to present to you today our speakers. First is Gavin Yamey, then we have Kara Hansen, Ezequiel Garcia-Lorio, Tolua Oni, and Freddie Sengoba. And first, I'd like to go directly to Gavin Yamey. And Gavin is the Himowitz Professor of Global Health, Duke Global Health Institute, Professor of Public Policy, Duke Sanford School of Public Policy, Director, Center for Policy Impact and Global Health at Duke University, Durham, North Carolina. Gavin, over to you.
Thanks for that very kind introduction, Miriam, and thanks for the opportunity to share key messages on UHC from the Lancet Commission on Investing in Health. We endorse something that we call progressive universalism, and I'm really looking forward to laying out what that means. Just to set the scene, the Lancet published the first report of the Commission on Investing in Health, CIH 1.0, in 2013. It was chaired by Larry Summers, former US Treasury Secretary, and Dean Jameson. And actually, that report, CIH 1.0, marked the 20-year anniversary of the World Bank's World Development Report 1993, which was also called Investing in Health. And back in 93, Larry Summers was the chief economist at the bank, and Dean Jameson led the report's development. We were 25 commissioners worldwide, including Agnes Binagwaho, Minister of Health of Rwanda, Lina Mahochlo, who was the governor of the Bank of Botswana, and academics worldwide. That report 10 years ago, findings, I'll briefly mention each, that a grand convergence in global health is achievable in our lifetime. We can touch it almost, we can definitely reach it if we make the right decisions, that the returns from investing in convergence are very impressive, that fiscal policies, taxation, regulation, and so on, are a particularly powerful and underused lever to curb non-communicable diseases and injuries. And we argued that progressive or pro-poor pathways to UHC were an efficient way to achieve both health and, importantly, financial protection. A grand convergence in global health. We showed that it was technically and financially feasible. By that, we meant a universal reduction in deaths from maternal and child health conditions and infectious diseases by 2035, down to the level seen in the best performing middle-income countries, China, Cuba, Costa Rica, Chile, for example. And our modeling had shown that we could do that with A, aggressive scale-up of today's tools, and B, importantly, the development and deployment of new tools. We know that countries that adopt new health technologies see an additional 2% per year fall in their mortality rate. And we included an investment case and showed that investing in convergence would return for every dollar somewhere between $9 and $20. Really an extraordinary return on investment. CIH 1.0 showed the value of population-based approaches to non-communicable disease control, in particular fiscal policies, like taxing harmful products. Tobacco is the example on this slide. Reducing fossil fuel subsidies. Many countries spend more subsidizing dirty fossil fuels than they do on health and education combined. Such taxation, of course, can generate finance for health. And I think that when we conceptualize UHC and think about financing UHC, these approaches are important. Increasing the price of tobacco, for example, in China. This is work by Stefan Vergey and others, Prabhat Jha. The 50% rise in tobacco price from tax increase in China would prevent 20 million deaths, generating an extra $20 billion a year in the next 50 years. That tax revenue would, of course, fall over time as smoking declined, but it would still be higher than current levels even after 50 years. And this is pro-poor because it is the lowest quintile who will gain the largest share of life years. We also noted on NCDs, this is obviously important for UHC, that an expansion pathway would begin with basic clinical package of interventions, the ones that are laid out, for example, in the WHO's best buys for NCD control, and then countries would follow an expansion pathway that would then build upon those essential packages, adding in more aggressive screening and treatment for a broader range of diseases. And finally, this is the famous UHC cube that sort of is a guide star, lodestar for many of us, showing the 3 dimensions of coverage. We in the Commission 10 years ago proposed a pathway that we call progressive universalism that's shown by this blue shaded area, publicly financed pro-poor UHC to achieve better health outcomes and financial protection. And it argued that the initial the initial package, this blue shaded area, should include interventions for conditions that disproportionately impact the poor. That is the convergence agenda and this essential package of interventions for non-communicable diseases and injuries. It is pro-poor in its choice of intervention. And we argued that the main features of this is that the whole population is covered. There really is universalism. You are targeting the poor by including interventions that disproportionately will benefit the poor. You fund it ideally through public finance, tax revenues, potentially payroll taxes, no out-of-pocket expenses for this very defined, explicit package. And then as the resource envelope grows, you include a wider range of interventions, the sort of Mexico example. The benefits are that the poor gain the most, high health gains per dollar spent. You're using public finance to address the negative externalities of infectious disease transmission. And we've seen this approach work in many countries. Rwanda, Mexico are two examples. 5 years later, we published CIH 2.0. That marked the 40-year anniversary of Health for All, Alma Ata Declaration, and we presented CIH 2.0 at the 40-year anniversary event in Almaty. And in the 5 years since CIH 1, the world had changed, and Richard Hall asked if we could kind of reflect on those changes, new health threats, demographic shifts, geopolitical shifts, obviously the transition from MDGs to SDGs, challenges to UHC into health finance, and a range of environmental threats. And we asked, are we on track for convergence? What does primary healthcare look like in the context of the UHC movement? And what is the role and the future of development assistance in supporting convergence, UHC, and SDGs? We were, by the way, in 2018, seeing great progress on HIV and child mortality, less promising on TB and maternal mortality. Clearly, there were some challenges to UHC, pandemic risk. We're actually seeing a divergence on non-communicable disease mortality, worsening in many low and middle income countries like China, continuing to improve in many high income countries, partly due to inequalities in treatment and lack of progress on risk factors. We were seeing demographic shifts, aging populations, for example, exacerbating NCD control challenge and multimorbidity. We know that many health systems are poorly equipped. In CIH 2.0, drawing on DCP3, we tried to sort of move away from the fuzziness of UHC, the kind of everything to everybody, what Julio Frank has called a sort of empty promises, a swamp of empty promises, to say, look, here is a concrete notion. We can look at the evidence, clinical evidence and cost effectiveness evidence to find interventions that provide value for money, they're feasible to implement where resources are scarce, and they address a large disease burden. That led us, with the DCP3, to identify 218 essential UHC interventions, almost all of which could be delivered in primary care through primary care platforms, population-based, including taxation and regulation that I mentioned earlier, in the community, at health centers, and at primary level hospitals. We also defined an even narrower package for the lowest income settings with 107 interventions. These would be complemented by intersectoral approaches, and then we costed those packages about $100 per person in low and lower middle income countries, and found that many lower middle income countries could afford around 80% coverage of these essential packages by 2035, but low income countries would struggle with the domestic finances alone. And finally, drumroll announcement, we will have a CIH 3.0 report, if all goes well, about a year from now, or maybe a little bit before. We have begun work on essentially a 10-year update. We will be examining again how much progress there has been on convergence. And we have had several meetings, and I have to say, the progress is very impressive. I know that sometimes things can seem bleak in global health. There has been impressive progress. We will be examining the feasibility to a longer time frame of what we're calling 50 by 50. Would it be possible for every country to reduce premature deaths before the age of 70 by 2050 from a baseline of 2019. We will be laying out pathways to better health by 2050. What do those interventions look like? How much will they cost and how will they be financed? We will show how health gains contribute to economic welfare, and we will try and quantify some of the health threats ahead. Thank you very much, and I'm so looking forward to hearing from the other commissions.
Thank you very much, Gavin, for that presentation. And now I'd like to introduce Kara Hansen, who is the Professor and Dean of Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine in the UK. So Kara, over to you.
Thank you so much, Miriam and Jessamy. It's such a pleasure to be here and to be on a panel with such distinguished friends and colleagues. So our commission, the Commission on Financing Primary Healthcare, was published in April 2022, so just over 18 months ago. And our starting point was kind of what's so special about PHC financing. There's been quite a lot of discussion about financing for universal health coverage, and we recognized primary health care as the foundation for universal health coverage, and very aligned with Gavin's commission on investing in health, with the idea of progressive universalism. That's because that PHC package is very much the starting point. Universal access to that PHC package is very much the starting point for where we want to get to. But in reflecting on what's special about primary healthcare financing, we were recognizing that in general, priority to health in government budgets is limited, and there's a whole set of professional and political pressures that mean that health budgets tend to be allocated in ways that favor hospitals. What that means is there's not enough money for primary health care. It also means that the resources don't actually reach the front line. There's many forces, legitimate and illegitimate, that stop resources from getting to those frontline providers. And also that the way the constellation of funding works is that PHC funding is fragmented, inefficient, and inflexible. And so that leads to kind of our message was what would better financing for a people-centered approach to PHC look like? And it would be to allocate more resources to primary health care, to allocate these in equitable ways and protect them until they get to those frontline providers, and then to think carefully about how to align funding flows and incentives so that providers are able to use those resources in a way that is responsive, flexible, and efficient. So we started with some stylized facts just to give you a sense of what government spending on PHC looks like in low and lower middle income countries. And just to give you a sense of the scale here, just to hook onto Gavin's point that an essential package of PHC might cost something like $100 per capita, and to compare that with these levels of spending that we measured using the Global Health Expenditure Database of $3 per capita on PHC in low-income settings and $16 per capita in lower middle-income settings. I think everyone who is here will recognize that out-of-pocket payments are a really important source of PHC financing, even in upper middle-income countries. So it's really hard to crowd these out, but really important. But also that a big share of these out-of-pocket spending is made up by medicine. So I think PHC financing needs to think really hard about how do we provide better access to medicines, particularly for chronic conditions. And finally, just to pick up a last data point, that how much government spend matters because the level of spending is highly correlated with better service coverage. So this is it's a log scale on the bottom looking at the level of government spending on PHC per capita against the UHC coverage index that our global agencies monitor on. And you can see that there's a very strong positive correlation. You get more coverage if you spend more. However, just to note, there's also very high levels of variation around that average. And so if you were to draw a vertical line at about $5 per capita, you can see that countries are achieving anywhere between 35 and 75% coverage of these universal of these service delivery indicators. So how you spend the money matters as much as how much you spend itself. So our inquiry really looked at four main topics. One was how to raise more money for health and how to do that in a progressive way. How to allocate more to PHC, and then how to align incentives. And finally, we also looked at some of the political economy issues around these financing issues. So I won't go into much detail about these, just I suppose to highlight that these allocation mechanisms, which are really about budgets, but how governments use their budgets and how they use their budgets to achieve certain health objectives is really important. So we did quite a deep dive into budget formulation, budget execution, and then also how the ways in which how you configure your primary healthcare services can itself act as a lever for drawing more resources to the primary healthcare level. So we identified in each of those boxes in the bottom left-hand side a set of policy levers that governments could use to allocate more to PHC and to allocate more equitably. We also had an expansion pathway. So the figure on the right is about how to align incentives at the provider level in favor of a coherent, comprehensive, high quality, equitable package of services delivered at the PHC level. So we talked a lot about different ways of paying money to providers from pooled funds, and how you could imagine a pathway that would start from the most common mechanisms now, which are either input-based budgets or some kind of fee-for-service approach, through to an approach that's based on capitation. And we argued that capitation is a really fundamental. It's fundamentally aligned with a people-centered approach to PHC and to paying for PHC. It starts with an equal amount per capita paid for to the providers. This is an amount that's paid for every person who is, let's call it, registered with that provider, although it doesn't necessarily have to be a registration or an empanelment system. It then can adjust that capitation to make it more sensitive to health differences in the target population. And then ultimately, capitation can be combined with other types of payment mechanism in order to achieve a broader set of goals. And those advances along that, that expansion pathway all require stronger systems, better data, more capacity in the health system. And we noted those in the bars underneath the arrow. Think of better information, purchaser capacity, provider autonomy, and the flexibility and strength of PFM systems. And that would really allow you to move to a situation where incentives are more aligned with people-centered primary health care. We also talked a lot in the Commission about the political economy of financing primary health care, and recognized that the best laid technical solutions will get you nowhere unless you have a political strategy as well. And so we looked at instances of countries that had kind of used a political moment or opportunity to redirect and reorient its health system towards PHC and the design of financing arrangements that would underpin that. And so I think there was kind of 2 points that came out of our political economy thinking. One was that we often think about the political economy as a constraint, and actually more often than not, where change is possible, it's because the political economy has provided an opportunity. So it's worth thinking about those opportunities that changes in politics create. But also that our technical strategies need to be politically informed. They have to be aware of stakeholders and how to involve them and engage them in designing policies that will meet the needs of different stakeholders. So we concluded that countries need to spend more and spend better on PHC. These messages align very well, I think, with the messages that came from the Commission on Investing in Health, that public resources should form the core of PHC funding, that pooled funds should cover PHC first. And that's really, that's a very similar notion. It's based in that same idea of progressive universalism. That resources should be allocated equitably and be protected until they reach frontline providers, and that provider payment mechanisms should really try to move towards systems that have capitation at the core. I'm just going to skip to what's left. And so we also recognize, and really, I guess over the discussions that we've had with many of our colleagues, both at the country level and at the global agency level, about what are the bits of that our Commission didn't really fully address or resolve. So one is this notion of financing arrangements across levels of care. It makes no sense to focus only on these arrangements at the PHC level if they are going to run into and indeed conflict with incentives at higher levels of care at the hospital level. So there's a real need to be deliberate in designing provider payment mechanisms and incentives across levels of care as well. The medicines idea I've already pointed to. I think that we are not nearly creative enough in terms of thinking about different ways to deliver and finance medicines for primary health care, particularly thinking about long-term conditions and in instances where medicines are needed to manage chronic conditions. I think there's a whole bunch of quite interesting developments around new models of PHC delivery, thinking about primary care networks, thinking about how do we really integrate gatekeeping, and then how do we design financing arrangements to not just to support these, but to really drive them forward. And finally, I would say my biggest regret is that we didn't have much to say about the role of the private sector in delivering PHC. And certainly in urban areas, in big conurbations, that whole primary care market is so complex, it's so pluralistic, it's very noisy, I think, from the perspective of patients. And yet we did not find very good evidence of solutions that could really integrate the private sector in ways that could be scaled. There's lots of relatively small experiments, but nothing that could be delivered at scale. I think that's a really important area for future policy development. So I'll stop there just by acknowledging the commissioners who were outstanding and a fantastic group of people to work with. And then to turn back to Miriam. Thanks.
Thank you very much, Cara, for that presentation. Yes, we'd like to now turn to Ezequiel Garcia Lorio, who is the founder of the Institute for Clinical Effectiveness and Health Policy in Buenos Aires, Argentina. Ezequiel, over to you.
Well, thanks for the introduction. I'm one of the founders, not the founder, just to acknowledge the other ones. Thanks again. Greetings from Argentina. Good morning, good afternoon to everyone, and thanks for the invitation again to attend this session. I haven't prepared slides, so I will try to speak slowly and try to deliver my message the best way I can. I had the opportunity to be part of maybe one of the oldest commissions that has been selected for this presentation. It's been published 5 years ago, and it was led by Maria Crook from the Harvard School of Public Health and Mohamed Pate from the former Nigerian Minister of Health, and 30 people participate in this commission that try to contribute to UHC from a different perspective from the ones that my colleagues already presented. Our intention was to highlight the importance of quality of care in low and middle income settings. There has been several reports published about the state of quality of care in different settings from other countries years before. And for some reason, in 2018, there were 3 reports published simultaneously. One from the World Bank, the WHO, and the other one from the OECD. And the 3 of them try to highlight the amount of harm that and waste that it's in place in low-income countries, considering the low quality of services that people receive in our settings. So when Margaret decided to title this commission as Improving Quality of Care for Health Systems, Time for a Revolution, I believe that all of us wanted to highlight the importance on trying to deliver appropriate care to all settings around the world, which is perfectly aligned to the concept of UHC. So again, the panel was, the members of the commission were 35. 3 of us were from Latin America and others from all of the regions of the world. It was a combination of governmental officials, funders, and academics and practitioners from different regions of the world. I would say it was it was a great opportunity to be part of that commission for many reasons. And the paper that haven't lost any actuality in the last 5 years, I invite you to read it again. It's composed by literature review of different sources of trying to understand what's the evidence level of lots of published manuscripts that has been published along the years around quality of care in developing countries, case studies for these regions, and again, put some light on what's the evidence of different interventions that have been available for many, many years, trying to improve care in our settings. And I would say that, in my view, our contribution to UHC is that we have showcased the importance of effective coverage, just trying to provide everyone the interventions that they deserve with the less financial burden as possible. And so for that, what this commission made is to create a new framework for quality of care that it's based on previous frameworks. For example, the ones that Avedis Donavidian created in the 70s, and then we added the perspective from WHO building blocks and other frameworks like the Guaranteed Health Reform Right and the Durham Trilogy, among others. So this framework is composed, I will just describe it in talking about it, and by the foundations of healthcare, which are the population, the governance, the platforms of the delivery services, the workforce, and tools, which impact in process of care. And I will get into this in a minute, where we're measuring competent care and systems and positive user experience. But as maybe probably everyone will agree, the quality impacts that we have to have in mind is better health. We need to improve clinical outcomes. We need to reach confidence in systems from users. And finally, as my two previous colleagues mentioned, the importance of economic benefit of quality of healthcare for health systems abroad, for all. Because the thing is that no resources will be able to be available for everyone. So it's important that we select the right interventions to produce the economic benefits that especially low and middle income countries require from health systems. So again, just describing the different outcomes of the framework that we propose. Better health, it's related to health outcomes. The confidence in systems, again, it relates to satisfaction, the importance of recommending health systems to other users, trust, and care uptake and retention. And finally, as I mentioned, the impact of economic benefit on the ability to work or attend school, not to keep your daily life as it went before you get sick, you got sick or your family member got sick, contribute to economic growth, reduction in health system waste, and financial risk protection. And the last two components I like to refer to whenever I talk about process of care is that health systems should be evidence-based, effective, should also provide the right diagnosis, the appropriate treatments, counseling and referral, and should be capable systems to provide safe care for everyone. Regarding positive user experience, the Commission defined that user experience should be composed by providing care which is respectful, with dignity, privacy, non-discrimination, autonomy, confidentiality, and clear communication, among others. So again, we're trying to contribute with concrete aspects of user experience that could be measured. And also, as I mentioned before, the competencies of health systems to provide the care that we are intended for. So again, the Commission tried to review what had happened in the field of quality of care for low and middle income countries for decades, try to up the evidence levels on different interventions, and to provide a new framework that measures what matters to people and health systems. And trying to get to the recommendations of the Commission for the report, there were 5 main recommendations that I invite you to read in the manuscript, in the paper that was published. That care that people received, it's often inadequate and poor quality. And this care is common across conditions in countries with the most vulnerable populations faring the worst. We all know this, but it's important to highlight that care is inequitable, especially for the ones that have the less resources, the less education. And this, of course, has been highlighted by the pandemic, when countries that has the highest level of inequalities suffer the most. Another recommendation or finding from the Commission is that high quality health systems could save about 8 million lives each year in these regions of the world. And this is not related to providing exclusively more care to populations, but to provide the right care to people inside the health systems. Because from those 8 million lives that are lost each year because of poor quality, 5 million are related to poor quality of care given inside the health systems, not outside. There are people inside the system who have already access to healthcare systems. Finally, moreover, we should measure and report what matters most to people, such as competent care, user experience, health outcomes, and confidence in systems. As already mentioned in the framework, these are the measures that we have to have in mind. And I propose the panelists to a question about the future of this commission, and I will elaborate more about this. And then also that it's important that new research is crucial for the transformation of low quality health systems to high quality ones. We need to contribute with research findings that guide decision makers on how they should transform policy based on research findings on what's more effective for populations. And finally, and that's the biggest lesson for me, because I'm a clinician that has worked in quality of care for almost 25 years. But as I get more into research and more into policy decision making, I understood finally that the only way to change the system is that we conduct system-wide actions. What seems obvious, but there are lots of efforts around the world trying to improve care at the microsystem level, which is of course very needed and important, but it's critical to understand that unless we develop system-wide actions, things will not change consistently. So again, and ending my participation, I would like to mention that the four main domains of recommendations of this commission were classified in governance, platforms, and workforce and population. So from the findings of the commission that I already mentioned, it's critical that we understand that we need to govern for quality. We need to have a shared vision, manage, regulate, strengthen, try to demand accountability and learn for governments for this to happen. Then we need to redesign service delivery. We need to reorganize services to maximize health outcomes. Also, we need to transform the workforce to strengthen free service education, support the work environment. And finally, the most difficult thing, which is to ignite demand for quality from the population. We need to instruct the population about the importance of quality of care and that they have a very important role, and it has been shown by research, because active populations get better results. So it's important that we share information on quality and develop active patients. So just trying to narrate the findings of the commission, it was a pleasure to be part of this amazing group, and I would like to elaborate more whenever we have the Q&A about the future of the commission, because this commission led to very active work that is trying, again, to contribute to the quality of care in our regions of the world. So over to the moderators. I hope that my interventions were in time, and thanks again for the invitation.
Thank you very much, Ezequiel. That was wonderful. We're now going to move over to a country-specific commission, talking about the Lancet Nigeria Commission from Tulula Oni, who is the clinical professor at the University of Cambridge, founder and CEO of Urban Better in London. Tulula, over to you.
Thank you. Thank you, Miriam, for the kind introduction. It's been really great listening to the speakers so far. I'm learning a lot. Yes, it was a real honor to be a commissioner on this quite exemplary commission on investing in health and the future of Nigeria, and just to acknowledge that I'm presenting this on behalf of the commissioners and the research team. I want to start off with the acknowledgements. I mentioned the commissioners and the research team, but we also took a very co-production approach, a very diverse approach to putting this together. And there were several individuals that supported, contributed to the report from different sectors, not just academia, but civil society, in helping with case studies, etc. So just want to acknowledge them as well as the funders. And so, yes, we had a first, actually had a first meeting in September 2019, and the first in-person meeting, first and last in-person meeting for obvious reasons, was in January 2020. And it brought together commissioners with diverse expertise from health and epidemiology to political science, history, economics, law, etc. But we also had engagement with policy representatives and actual implementers involved in the commission. I think that really proved really crucial, as I will show you. So a little over 2 years later, we published the commission report, as you see there, and there was a launch event in Abuja, the capital of the country, that was chaired by the vice president at the time, and with many of the commissioners in attendance. The report was actually published along with a disease burden report that compared health outcomes in Nigeria with other West African countries over a 10-year period, and I will share some of that information. And we had really extensive engagement with policymakers, media, social media, etc. But obviously, we'd been engaging with them over the course of the commission, and that proved really critical. So I'm going to share three key findings. So I'm talking about the health outcomes we found around policy and around financing. Obviously, there's much more, and I encourage you to read the report. But under health outcomes, one of the things that we found, so the life expectancy of the country was just over 54, which is the 5th lowest in the world, and that this was worse than countries with similar GDP, particularly the maternal mortality ratio was particularly low. And when we compared to the other West African countries with equivalent of lower health expenditure, we ranked 6th in terms of age standardized death rates, 13th in under 5 child mortality, and 14th in years lived with disability, predominantly due to non-communicable diseases. And what this really highlights is, in spite of that, we're not getting bang for a buck, right? So there's need for greater investment in healthcare, but really need for a more systems approach, as a previous presenter just shared, and really to strengthen across the board, but also the importance of a strong focus on health determinants. So that was what we found. That said, we also did find that over that decade, or the 2 decades rather, mortality did drop across all age groups, and life expectancy did increase, and level of disability was also going the right direction. So I think it's really important to know there's a lot more to be done, but actually the trend was going in the right direction. So that's kind of motivating to keep going. The second category of key findings I want to present is around policy. So we found that there was a whole expose on looking at the history of the development of the healthcare systems in the country, really rooted in a colonial legacy that meant that the healthcare was and remains skewed towards curative rather than preventative disease. Particularly notable that there is an unequal distribution of health centers between different regions. So huge inequality. So when we're talking about the country, it's important to look at the different sub-regions. So the North particularly had a significantly lower score in terms of access to quality healthcare. We found that the health policy is ill adapted to the burden of disease. So the main risk factors driving ill health in Nigeria really point to the need for health creation and disease prevention, but that wasn't aligned with actually how the health policy was being implemented, and really pointed to the need for a health and all policies approach. And lastly, the impact of policy reforms that had been implemented in the past had been found to be limited by governance and accountability roadblocks, either related to governance arrangements between the different levels of government, so from federal to state to local, a lot of fragmentation and lots of accountability. That said, so you can see the pattern of my slides here. That said, there were notable improvements in infectious disease surveillance, which resulted in timely national data reporting and action on outbreaks, including COVID, including Lassa, including actually Ebola, which is not mentioned today, and monkeypox. It was certified free of wild polio virus, and a huge amount of that was due to the engagement of traditional and religious leaders as part of health promotion. So again, we can see, yes, things are not adequately aligned, but you're seeing some strengths that represent areas to build on. And lastly, a key finding around financing. A significant amount of healthcare financing for the population was through out-of-pocket expenditure, 78%. And health expenditure is quite low. There's a significant dependence on donor spending, which is largely uncoordinated and inefficient with lots of vertical funding and siloed funding structures. Again, that said, there is the starting point of this basic healthcare provision fund and state health insurance that had been started and was highlighted as an important starting point towards universal health coverage. So I think what was really nice about this commission, because it was not just being put together by academics, but by implementers as well, we were able to, yes, identify what the deficits are, but really identify what some key markers of progress and areas that could jump off points, as it were, that could be built upon. So we had 7 recommendations overall, which I won't go to in the interest of time, but they related to engaging with better in a coordinated way with the private sector, which is one of the earlier speakers alluded to, in a coherent way, particularly around increased local production of vaccines and medicines, etc. There was recommendations around addressing the deficiencies and imbalances in the health workforce needed, around a coordinated approach to community engagement, and really the need to overhaul the healthcare system. But what I do want to focus on is 3 key recommendations. The median age in the country is 19, thereabouts, certainly 18 in the city in Lagos. So with that kind of young population, in Lagos, its biggest city, 75% of people are under the age of 30. We really should have health prevention at the heart of public policy, of health policy. And that requires multisectoral actions, which have a high benefit to cost ratio. And in the commission, we highlighted some of those cost benefit analyses. And that really, we highlighted that would need to operationalize a health in all policies, approach. Now, I think this is really important to highlight, because often when we talk about universal health coverage, there is, and rightly so, understandably so, a focus on healthcare. But it is important to also note that UHC comprises more than just healthcare in the definition of WHO, and that it involves taking steps towards equity, health promoting development priorities, social inclusion and equity, and public health. So that's often forgotten. And I think this is one of the things that we really teased out on there. The importance of a place-based approach, really looking at these environmental drivers of ill health. And then we proposed a sort of rethinking of a new social contract in the country, really using health as a political lever. So, in the context of a very young population, could an investment in health and as a way of really understanding and recognizing the assets of the country be a way of redefining the relationship between the city and the state, and actually leveraging that as a critical political lever? So those were kind of just some key recommendations I wanted to highlight. Have those recommendations been taken on board? I think this is one of the most remarkable experiences I've had in terms of political impact and policy impact. likely related to the fact that we had this co-production approach, engaging with the policy implementers from the start. So as part of the recommendation around the need to overhaul the national health system and also to rethink financing, the presidential press release acknowledged our recommendations, and the National Health Insurance Authority Act legislation was put out in May 2022, so a few months later, mandating health insurance for unemployed people and particularly the poorest countries. And in fact, several commissioners were invited to serve on that health reform. So I think that was a really nice example of the impact of that level, that very complex and system level. One of the recommendations was also around to implement enhanced systems to support this planning and monitoring and accountability. And particularly, we recommended a Nigeria Medical Research Council be created. And this act is now currently in progress and going through the government processes. Just briefly to note that the DCP4 on Nigeria was based on the report, thinking about health promotion. There was a sugar sweetened beverage amendment to the Finance Act in recognition of the need for this multisectoral approach. The commissioners were invited to the Nigeria Governors Forum to speak about this report. And actually at the subnational level, one of the state's governors announced plans to deliver free maternal care based on the report. So really impactful. What more can be done? There, in terms of after the report, we need much more emphasis on the determinants of health. So one of the things that we found was around this impact on wash and on air pollution. So I'm going to zero in on air pollution for a moment and show that in Nigeria, across the country, in 2019 alone, the premature deaths from air pollution exceeded those from malaria and were more than double those from HIV. And in Lagos alone, that was around almost 24,000 premature deaths attributable to air pollution. So this is a huge amount. When we look at what what the implications are of that from a financial perspective, if we actually put in place levels to acted on levers to address air pollution in Lagos, which is the biggest city, between 2023 and 2040, that would save the city about 12 billion. And that's equivalent to the 65% of the country's public spending on healthcare in 2021. So really, we can see how, as well as making efforts towards tackling greenhouse gas emissions, equivalent to about 85% of the country's greenhouse gas emissions. So we can start to see how we're just leaving value on the table here. And in terms of thinking about climate and health, I think really important to highlight that, if we're going to future-proof any interventions, we're going to have to do better at integrating. And one of the things that we recommended was around placing health at the center of climate action and integrating health into the country's NDCs. So just to end off, there was a couple of cross-cutting lessons from the pandemic, kind of just reflecting on that, because obviously this is happening about the same time. And I just want to highlight two. One is equity, and one of the things that really came through in the country: geographical equity, socioeconomic equity, the importance of ensuring any recommendations are explicitly designed and implemented through the lens of equity. And one of the things we saw from the pandemic is that could be stronger in supporting lockdowns particularly for poor families and children. On the flip side, we also recognize the importance of a whole of society engagement. And one of the lessons from the pandemic is that we really saw the private sector in the country, civil society and community groups coming together and mobilizing to act and to protect health, to protect livelihoods really across the country. And I think that really I wanted to end there because it rings home to a key recommendation that we put out, which was to operationalize a multi-sectoral response to health, this health and all policies, whole of government, whole of society process, and having an integrated planetary health governance approach to improving health. So with that, I think, end. Yes.
Thank you very much, Tallulah. And it was also wonderful to hear about the power of Lancet commissions with your recommendation on the Nigeria Medical Research Council now being in progress. So that was very exciting to hear about. I'd like to hand over now to Freddie Senguba, who is the Professor of Health Policy and Systems Management at the Department of Health Policy Planning and Management at Makerere University in Kampala, Uganda. And Freddie, we look forward to hearing from you and on your reflections. Thank you.
Well, thank you very much. And really such a wonderful set of papers. I wish, first of all, to congratulate all the authors for these commission reports presented today. I believe many more that I've seen on the Lancet website. It really takes a lot of dedicated time and effort to produce these reports. I've been privileged to serve on one and another, and is ongoing. I can attest to the hard work and effort that it takes. So congratulations. This mobilization of knowledge from so many experts in different forms of commissions, I think for me is one of the things that I've had to reflect on as I was preparing for what I'm going to say. And among them, I just note that definitely Lancet has given us the platform, but also the convening and the support that takes to create a truly co-production of knowledge, and of course the interaction that takes between academia, policymakers, experts, editors, peer reviewers, and of course practitioners and funders all coming together. And I believe this is a truly a multi-sectoral enterprise, and I believe part of the reason these reports are enjoying the legitimacy that they have is the fact that these are being produced through a process that allows all of these contributions to be made and to make these reports truly actionable. I also want to, of course, recognize that this comes from the 200 years of commitment that Lancet has put in as a production house, and I salute the Lancet editors, current and previous, for the wonderful work that has been done to bring up this institution the way we now look at it. So congratulations. So coming to the papers, my first message certainly is about this innovation and the mode of curating policy guidance and advocacy from heterogeneous sources of knowledge. I've seen that in my own research, we tend to work on small action points of methods and the like, but really to get traction on major policies that are going, or major issues that society needs to solve major problems. I think this mode of trying to really work together, put together commissions, and be able to distill the essential recommendations is very important. And I think this is where the utility of this report is really coming from. Coming to the specific ones, I've looked, and of course I started with one on financing, but I know that when you look at the financing, the quality, the investment case that was presented first, and of course the country case study from Nigeria, this almost forms a rounded set of deep dives, and of course the country case, which I think is a very big contribution to us, or at least to advise and advocate for UHC. And overall, I don't think that there is information that we don't have, at least for the next 5 or 10 years, to try and advocate on what needs to be done. So congratulations. On the financing side, it's reassuring from the work that has been done by the Commission on Financing Primary Care to try and, first of all, provide a rich resource of analytics, new ways of presenting data, looking at different ways of making the case. And out of these, I've actually been able myself to learn and also pick on some of these for my classes. When I attended recently 2 conferences, I find that various people are using some graphics from many of these commission reports, which is a way to indicate that is actually moving into the right places. Specifically, I think the one of the messages that I love and I wanted to amplify is this issue that at any one level of financing or per capita financing at any one country, there's a lot that can be made. And I think this is one of the findings that speak to the issue of how do we finance better, meaning that in each country context, we should be able to explore ways to make better use of financing, how we mobilize the money, how we pay, how we create incentives, and of course, how we reform. And these, of course, countries like ours, and I am speaking from Uganda, we tend to think that's about more money to health, but I think there is plenty that many reports have documented of waste and or misuse. And I think I've also seen in some of the reports the sheer corruption that might happen along the way. All these are areas to indicate that there is room for us to examine how we make progress with UHC by leveraging better spending within the primary care sector. But also the next point I think is about how we prioritize. There is a lot of needs within the healthcare systems, and many times upstream or specialized care that happens to be an area where a lot of elites see themselves tend to take a big share. And so the call to try and prioritize the primary. Just to digress a bit to here in Uganda that is stopping us to make progress on some major reforms is how poorly we have financed the PHC setup, where the communities don't seem to see or have the confidence for them to be asked, for example, to pay for or to contribute to some of the health insurance programs that government is proposing. So this deliberate prioritization of PHC in the overall national health financing is welcome, and we really need to take that message into all areas of what we do. And then I like the optimism that the investment case, I can't call it an investment case, have been presented by Gavin. In other words, trying to indicate the feasibility for us to make major leaps in outcomes in terms of, and within a short time, if we are able at least to focus on a number of issues. And here he talks about a number of issues, but one of which is progressive financing and how we try to address tax financing to pick up on the major issues, especially on the basic packages that is enjoyed by the majority and the poor population packages that he talks about, as we try to innovate with contributional mechanisms to expand the pie. He also talked confidently about what we need to do in terms of progressive realization. And I think this is very much in line with the message that needs to be heard more and more, because I think at some point we also have the tension of trying to revisit the history of PHC, trying to do very little and trying to run with it, sometimes not really making a major leap in terms of the needs as they expand in our setup. As we note, our health systems have not only to deal with the primary care problems, but NCDs and high-level concerns to provide specialist care are here, and they are very important, and they have very big lobbyists. So we really needed to make sure that we do build these dual processes of ensuring that we do not in one way disadvantage the poor as we move into more and more expansion of care. Of course, these reports also speak to some areas that I find myself a bit drawn back. One is about the need for reforms and the multitude of reforms that ideally one can see across these reports. All of them well-intentioned, but when I visit the kind of primary care providers in our setting, I quickly realize how all these efforts can create unintended burden in terms of administration. The the crowding of the players that are supporting these platforms sometimes itself is beginning to create a lot of diversion of efforts. We are managing what we would call crowded spaces, where we have numerous agencies, many tools, incentives, some of them are aligned, some not, interest group power bases that all come to play on some of these platforms, and that in some way call for even more experienced managers that we can find at national level. And I think in there is where the challenge comes in terms of what we need to do, partly to make life easier. And I think the issue of simplifying other than complexing some of these reforms is something that we all need to, I think, work towards so that we are able to help where capacity is not yet developed. We don't want to crash it, but we want to slowly see how we build the capabilities for these reforms to be able to function. But in the meantime, I think I wanted to draw the attention to the need to have reform with a human face or PHC face, so to speak, and see how to help reduce the transaction costs that are increasingly falling on these low capacity and prepared PHC platforms. So a recommendation to simplify financial arrangements for PHC ought to be considered along the way to expand UHC and make progress towards it. The other element I want to talk about is the quality and the Lancet report on improving quality. I think this is very much an issue that it cuts across all reports I've seen, that it appears in every report in one way or the other. But fundamentally, I think it makes a point that we can, or we may not be able to make progress expanding the provisions without paying attention to quality issues. I've found, and I think they make a strong case about how trust and subsequently progress can be hindered if we constantly providing less than adequate quality to the communities. And if we are to do demand creation or any innovation that we want to bring more of the people that need the care most, I think it's important that we actually start by paying more attention to the quality of service, the customer experiences, and interestingly also they offer very interesting ways of measurement and metrics and frameworks that can be adopted as we try to monitor, learn, and of course transform this. There's also a big, I think, dividend that is mentioned there, about 8 million days that can be averted if we pay attention to how those that come into the health system are catered for. We don't want to see that even those who are able to access services do end up with this such big mortality. So we govern quality, and the whole reorganization that is necessary clearly is part and parcel of the agenda. Of course, this brings about more money and more costs. Quality itself is a costly enterprise. And I think this is where we really need to see how to juggle the game of increasing access, increasing quality, and of course, making sure that the little money that is available go little further. I know that part of quality is also about the workforce, it's about medicines, it's about in our setting, the quality of these medicines, the quality of these health workers all matter. And so some go back to training, some go to regulatory institutions and how they interface with these many times. And I think the political economy issues are also raised. We fail even to do effective research around improving drug quality, and yet we have very big prevalence of we could say products that shouldn't be on the market, or substandard that they don't give us the expected effectiveness. And I think these are all areas that we really need to capitalize in the quality agenda along with what they've proposed. And now I wanted to speak really about the Nigeria Commission. I like the commission
Freddie,
that...
can I just...
Sorry, speak.
If we could just, if we could wrap this reflection up maybe in the next minute or two, only because there's lots of questions. There'll only be 20 minutes for a panel discussion.
Wonderful, thank you. So I'll
Thank
wrap
you
up.
so much.
But this is important. I think as I was trying to prepare for this, I managed to watch many YouTube and recordings that come from the launch events in particular and subsequent dissemination event. I must say that I was very impressed by the way that the Nigeria Commission work has been disseminated and the whole messaging around it. And that, I think, brings me to the last part of what I want to say. Clearly, I think the COVID was, there was a kind of silver lining with it, because all these online availability of information and virtualization of meetings and processes enabled for me, and I believe whoever wants to look at these commissions, to look at all these recordings. And one of the messages that came through was that idea that, yes, we really needed to put some fuel behind these reports at national level, how we popularize them, and maybe ask the advocacy groups in different areas interested in UHC to see how to put this in the road. In other words, give some legs and some animation to these reports so that they can continue to actually mobilize the coalitions and improve the policy outcomes around UHC. So with that, I think I'm going to stop there and say this has been a wonderful experience for me, partly to read these reports and to see what a treasure that we have in terms of how we engage with governments and advocacy, and also mobilize all of government efforts. I think one of the findings that Nigeria and others have indicated is how we need to work across government, across leadership at all levels, and be able to mobilize action at all levels if we are to make a difference. I'll stop there, and thank you for the opportunity for me to be in this space and share with you his remarks.
Thank you so much, Freddie. That were amazing reflections, and you just brought everything together so beautifully and wonderful. I thought that was fantastic and such a treat to hear all of your different perspectives there. Thank you very much. I think we're now going to move into a bit of a panel discussion. We've only got about 18 minutes left, but there are some fantastic questions in the Q&A box. So I wanted to probably go straight to the audience questions so that we can get some of their participation for the rest of the webinar. There's a question here from colleagues in Peru who are asking about whether you could talk about how we could co-create a high-quality health system for TB prevention and control, working hand in hand with local government and community stakeholders. There's an urgency to adapt health systems knowledge to tackle and end TB, the disease of the poor. And it's obviously been, you know, a year of high-level declarations this year, UHC and TB being them. So perhaps we can go to Ezekiel, first of all, from a quality point of view, and then to the rest of the panel. That would be fantastic.
Well, thanks for the question. Just trying to be very brief and to make my point about the future of the Commission. The Commission led to something called QUEST, Quality Evidence for System Transformation. This QUEST initiative has led to another development, which is called Service Delivery Redesign, which is a model to understand, to evaluate problems in healthcare delivery, for example, TB, and other chronic conditions. And for that, what we're doing is we have work in Kenya, just trying to understand problems related to delivery. Also working in Argentina, trying to understand the problems related to hypertension and diabetes management. And going to the TB question, I have the sense that this service delivery redesign is trying to emphasize which are the capacity problems, which are the effective coverage problems that are in place, and trying to redesign care, understand the key points of providing the right care at the right moment and satisfying the experience of patients. So I have the sense that I'm not an expert in TB myself, but I understand the problem in Peru, which is very important. So having a system-wide perspective will be important to link the interests of decision makers, providers, and community. And the experiments that already Quest is running globally about service delivery design might shed some light on how to do this. Over.
Thank you so much. Colleagues on the panel, can we have some of your reflections on that, if you have any, please? just kind of jump in if you've got some.
Two quick things from me. One, oh, go ahead.
Go for it, Gavin, I think, and then we'll move on to the next one. And then
just very quickly, two quick things. One, there is a Lancet Commission on TB which just published an update focusing particularly on new tools and looking at progress, which in many countries has been really impressive. And then the Commission on Quality Health Systems did a spin-off paper looking specifically at TB that Margaret Crook and colleagues published. So worth looking at that one as well. Over.
Thanks, Gavin. And Tolu.
Yeah, just an additional reflection just to illustrate the earlier point of taking a comprehensive approach to UHC. I think TB is a really good example. You know, we've said for 100 years, TB is a disease of poverty. And then when we talk about prevention and control, we do nothing about the factors around. So it's a really good example of how we, yes, improve treatment. And I think there's been a lot of advances in that, in, you know, shortening treatment, the time period. But how do we look at housing? How do we look at ventilation? How do we look at malnutrition? There was a recent paper that showed that households of TB patients that actually had better nutrition when less, you know, it was kind of a protective factor. So how can we, when we think about treatment, how can we be more holistic and not solely focus on the pharmaceutical? Because at a population level, we should be really reminding ourselves to think cross-sectorally. And I think TB is a really good example of that.
Thank you so much. Any other reflections on this particular question before we move on possibly to dementia, I think, and perhaps Cara, you could talk to us about a very interesting question. Hom Shrestha asks, is there any provision of funds for memory loss and dementia care for high-risk and vulnerable older adults in primary healthcare facilities at the community level globally? What can be done for the community support for primary healthcare financing for care and prevention of dementia and memory loss from government and donor agencies? Cara, given your commission, perhaps you could start off with that one, and then colleagues on the panel, if you put up your hand, maybe actually in reality rather than virtually, I don't know if we've got that function, then we'll be able to know who else wants to talk to this point.
Thanks very much, Jessamy, and thanks for the question, Hom. I suspect that the short answer is that these are areas of care that are still somewhat neglected in low and middle income country settings. But I guess kind of two reflections on that. One is it's obviously going to be a massive problem in the future. So thinking about the pace of demographic change, the effects of population aging, and the inevitable effects of that on dementia and memory loss in older people. So I think it's something that's worth kind of planning for and thinking about. I think the other thing is the way that these interventions become parts of these essential packages, as Gavin was describing, are through evidence about the cost effectiveness of these interventions. And I think in the case of dementia and memory loss, I think we need to think quite creatively about how we capture those benefits in standardized ways. So, because there we're talking probably not about longevity, but we are talking about massive improvements of quality of life and also quality of life of carers. So I think that really forces us to think about what are the metrics by which we consider interventions and put them into this calculus of determining whether an intervention is cost effective and should be included in an essential package. Over.
Jessamy, I'd like to just jump in and say there's a related question about oncology in many settings. And so this and the prior question about dementia speaks to this sort of changing epidemiology towards NCDs in general. And I wondered if, Tulula, you might have a comment on this from the Nigerian perspective.
Well, I mean, one of the things that maybe just to reiterate the point around looking at the comparison paper that looks like the burden of disease, I think that secondary paper was really interesting because it was comparing to similar countries with similar GDPs or similar health care expenditure. And I think one of the key things that came out in Nigeria, and I think this is why the kind of narrative of prevention and multi-sectoral action came out so strongly, because there was such a big contribution to, in terms of disability, adjusted life years from NCDs, cancers being one of those. I'm just trying to remember if we kind of zeroed in specifically on cancer, but I think it was kind of more around thinking about those chronic conditions that are actually occurring in a young population. So I think that's the other thing to remember. We're seeing a rising NCD burden in a young population. And so the way to get on top of that has to be prevention. If we look at what are the most common factors that risk factors that drive many of the cancers, it's around diet, it's around physical activity, it's around air pollution. It's so we have to, with the young population, take a much more whole of society approach to stemming the tide of non-communicable diseases like cancer.
Thank you very much. I wonder if I might ask a question that's also coming up from a few of the participants, and also something I noticed that some of you talked about, but I'd like to hear sort of a clear reflection on, and that it has to do with trust and the role of communities as being central also in scaling up quality UHC and PHC. How do you think that can be more meaningfully developed within the UHC platform in the way that other, perhaps more disease-specific interventions have been able to do in the HIV and TB space, for example? Cara, it looks like you've got something to say, and then Ezekiel.
I was just thinking about trust and financing, actually, and thinking about, because I think one of the common messages across these UHC messages is the importance of government financing. Where do governments get their money? They get their money from people paying taxes. And so I think there's a really important piece here about that social compact that assures people that if they pay their taxes, and I don't mean necessarily personal income taxes, because the tax base is often quite small certainly in low income settings, but even paying things like value-added tax and the other types of tax that governments collect to provide public services. There needs to be belief and trust that if you pay your taxes, you're going to get something in exchange for them in terms of public service delivery. And I think in many places that trust has been really badly eroded, and people's willingness to contribute in advance, whether that's to social health insurance or to tax collection, is really it's really limited. And I think there's something about flipping that to show that that the service delivery platforms can be trusted, and therefore it's worth financing.
Thank you. Ezekiel, please.
Hopefully, something to add, that the quest after the commission conceptualized a new outcome that is described as health security, and it's a combination of affordability and the conviction that someone will receive eventually quality of care whenever they need it. So these two together created this concept of health security. And today, it was published on the Lancet Global Health, a series of papers derived from Quest. 7 papers have been published with using what is called the People Voice Survey, which is one of the contributions from Quest to the world. It's a survey that's trying to evaluate and to gather information about the people perspective about the healthcare they receive. And this concept of health security is reported in the first paper, describing 15 countries on how they perceive their predictability, their prediction of afford healthcare whenever they will eventually need it for it, and also the chance of getting the right care, quality of care. And this is very aligned with the concept of UHC. So I believe it's very timely that today this was published, and hopefully this concept of health security will be of interest for decision makers. Over.
Tallulah,
Who's got her hand up?
Yeah.
Yeah, just a quick reflection on trust, because I think it goes hand in hand with something else we haven't mentioned, which is around misinformation and around, on one hand, and on around governance on the other. And I think we really can't untangle these, and I think that's really important. The example I gave in Nigeria around the polio virus has been really critical to that. The traditional leaders and the religious leaders been really critical to bringing the communities and building trust, along with bringing their trust along with. This is a really, really good example, because often we try to build trust from either from top down or in the middle of an emergency. Terrible times to try to build trust. We have to build trust in peacetime, as it were. And and a key part of that, I like how you previously framed it around, if you're looking after and if you actually believe that your public funds will go into building the healthcare system, and you're actually being engaged and you're actually being listened to, and your needs are being recognized. I'll give you a short anecdote from the UK in the middle of the pandemic, just to illustrate this. I was doing a kind of public engagement activity around when the vaccines were starting to roll out, and there was huge hesitancy and concern. And actually, the first thing to recognize, which we didn't do well enough, I think, is that some of that hesitancy was valid. Like, we were very quick to dismiss people, always misinformation. Some people were just skeptical because they needed to know more, right? And some of it was because they were just based on their experience. So I was in this kind of Insta Live event, and somebody sent a question to said, and because a lot of there was a lot of hesitancy, particularly in ethnic minorities in the UK, and somebody sent a question to say, why does the government care about us now with a vaccine when they say that obesity is a risk factor for COVID, and yet no one seems to care that we don't have access to healthy food. No one seems to care that our environment is unhealthy. And suddenly you care about us now with a vaccine. I mean, that is a fair question, right? And I think until we realize that in order to build trust, we have to listen to people. We have to understand what their needs are, their upstream healthcare needs are, not in the middle of an emergency, and actually take a robust approach to addressing that as a really critical way of building trust to build population health. So I think that was just an anecdote I wanted to share.
Thanks so much. Miriam, you said, why don't I ask another question? But it's actually 27 minutes past, and I don't think that we can run over. So why don't you ask Zoe Mullen's question, who's editor-in-chief of the Lancet Global Health, and then we'll wrap up.
I think that's a wonderful idea. Thanks, Jessamy. Well, Zoe Mullen asks, what could the Lancet do better in terms of the commission program? What topics have we neglected, or how could the process work better? So perhaps the panelists can reflect briefly on that. Thank you. Gavin.
I think that one thing that I've learned from today is about amazing interconnections between commissions. So I think there needs to be a meta-analysis of all the commissions to try and sort of find the lessons across them before you commission any other commissions.
Excellent. Thank you. Cara.
I wonder whether it might be interesting to have a call for expressions of interest to run commissions, and then that way some of these neglected topics might bubble up, and there could be a process of selecting some that are already high profile, but there's a good evidence base to communicate, and there could be others where the evidence base, where the topic is less well established, but a commission could really serve as a launching pad for it. But kind of an open call, and then the editors could select according to a set of criteria.
Thank you. Ezekiel.
No, I agree with Gavin in the interconnection of commissions, but we all want the same, so it's of course it's alienated. My suggestion would be, if I don't know if that's a mechanism that already exists, is that if commissions could be updated after some years, because I would say that sometimes things are the same and sometimes they're improved or changed on not the right way. But again, it will be interesting for readers to have updates on those. Over. And the meta-analysis point is great. Hope it's very difficult, but it will be very important. Thank you.
Thank you. Tallulah.
Yeah, I like the idea of the learning across, and I think just to build on that, sharing of the best practices across in the how-to. So, because one of the things I heard in a couple of In Lancet, another one is around co-production. And everyone said the importance of political strategy and buy-in, and what the Lancet Nigeria Commission achieved couldn't have been achieved without taking this transdisciplinary approach. So that's, I think, maybe an example of this best practice that could be shared across, and I'm sure there are others. So sharing the best practices and what worked would be great.
Righty, I think we have about 15 seconds before Jessami's going to wrap up. Do you have a last reflection?
Oh, sorry, what that?
Oh, I just asked if you had a last reflection, perhaps, before Jessami wraps up. Yes.
Thank you. I think I'll make one especially related to Zoe's question. One is about, I think there is plenty of good products in all these reports. And as I was looking at what has been presented from the Nigeria Commission, what I was able to see in my search, I realized that maybe all the commissions may not enjoy the same way of trying to be taken down the stream to get to actors, and maybe, I know Nigerian Commission was special as a national one, but the vibe there and the kind of actions that I could see emerging from it, I think do speak to something we can explore. How do we take these reports, especially where we think they have unique impacts, to see that they are taken into customization, how countries can start to actually see what they can work with. And that is not a Lancet Commission issue, I believe, but the partnerships that we make along the way might be something that we also should look at downstream dissemination and coalitions to see that those are also put into the picture, so that once the product is there, the other team is able to take off. I think I'll stop there.
Fully agree. Thank you. And Jessami, over to you for the last word.
Oh, well, thank you so much. And thanks to all of our presenters. I mean, they were fantastic presentations. We heard really a very broad range of topics on universal health coverage, from quite technical to some of the more softer or sort of broader aspects. My choice quote was UHC as a swamp of empty promises, which I think does sound rather depressing. But I would argue that what we've heard today gives us huge reason for saying that universal health coverage is not challenging, it's complex, it's huge, has many different facets and levels. But I wanted to pull out something that Cara said, solutions will get you nowhere unless you take into account the political economy. And that political economy be an opportunity. And we saw that so one demonstrated the Nigeria Commission, who did have that impact. It was possible to get that National Health Insurance Authority Act signed in 2022. So we didn't plan it like that, to start from a kind of depressing place and end in a very happy place. But I think it does show what progress is by, the desire to kind of ignite the demand in the population and for the aspiration for a sort of whole of society action. Competing needs, and it's difficult to get political buy-in for a lot of these issues, especially something as nebulous sometimes as UHC. So populations being brought into these conversations more effectively and meaningfully, must surely be the answer. So that's all I really wanted to say. We've run over, but thank you to all of our speakers. Thank you for everybody for joining us today and all throughout the year for our Spotlight webinars. And I look forward to doing some more next year and being in touch with everyone. Thank you so much.
Thank you, everyone. Bye-bye.
Thanks for the opportunity. Bye-bye.